Welcome to everybody tonight at Glenn Grossman's webinar, to those that are here with us tonight and those that will be visiting us on YouTube. For over 20 years, epidemiologist Glenn Grossman has been studying and forecasting the distribution and determinants of disease globally. While pursuing his doctoral training in epidemiology, Glenn served for 2 years as an epidemiologist on staff at UNC Chapel Hill's Infectious Disease Clinic and taught epidemiology and advanced analytics at Duke Medical School. He's worked on projects with the US CDC, Military Health Service, Veterans Health Administration, National Institutes of Health, and Centers for Medicare and Medicaid Services, and has gotten his hands into almost every large healthcare data set owned by the US federal government. All views expressed tonight are Glenn's own. Okay, so would you like us to start with the questions that you wanted? Or here, why don't we start with the first question? Please, Glenn, update us on the COVID-19 pandemic, variants of concern, and vaccinations in US and abroad. In particular, can you tell us how the world is dealing with the Delta variant?
Absolutely. Thanks for the introduction, and thanks everyone for joining. All right, so here, let's just dive in. Let me share my screen. Oops. All right, share screen. All right, so I have this graphic. As we've been talking about previously, now the vaccines are extremely effective. So the people who are being hospitalized now are vastly outnumber the unvaccinated, vastly outnumber the vaccinated now in terms of the people who are getting vaccinated and the people who are dying. So now we've had all these people who've been complaining about the vaccines, and they're the ones who are now in the hospital, and it's very disappointing. But we don't have great strategies to convince them, and so hopefully by doing more of these webinars, we'll be able to bring people on to understand. But let's look at a high level in terms of what the world looks like now. So we do know that there's a seasonality component here. We've talked about that before. The summer is not the typical cold flu season. So the fact that the Delta variant has been rising so much is very unusual, and it has to do with the fact that this is still a novel virus, and a lot of people have no immunomemory. When you look at the United States, you see that it's the end of August, and the cases are still rising rapidly. United Kingdom rose rapidly. We talked about them previously. Then they started to drop, and now you see that they're rising again. It's still, but however, when you compare this, so right now we'll just look at United Kingdom and the United States. When you compare that to the hospitalizations, there's not a lot of hospital data for these other countries, but you see that for the United Kingdom, the hospitalization rate is far less than what it was based on the cases. So again, this was the hospital patients. You see how low it is down here, whereas the cases up here for United Kingdom were quite a bit higher. So the vaccines are working a lot. They previously had a lot of people infected. So I think at this point, it's like 96–97% of the population in the United Kingdom have either been vaccinated or previously infected. So there's only a small percentage of people who have not had any exposure. So that's why the safety is so, the so few people are being hospitalized as a proportion. In the United States, unfortunately, we still have a fairly large percentage of the population that has not been vaccinated or previously infected. And they tend to be younger, but even though they're younger, there's many tens of millions of people who fit that definition. And so we still are seeing a lot of people hospitalized and a lot of people who are still dying. We'll talk about this at the United States. So let me switch over to this one. All right, so where is this mostly occurring right now? You can see most of the cases, as in last summer, most of the cases are occurring right now in the South. And for a couple of reasons. One is the seasonal component. where in the South, when it gets very hot and humid, a lot of people tend to spend more time indoors because that's where the air conditioner is, it's cooler. Whereas in the Northeast and much of the rest of the country, in the summertime, we try to spend more time outdoors because it's just more comfortable outside. And so that's part of it. That's why we had the surge last year. And so that partly explains what's going on there now. The other thing that's going on now is the Delta variant. And the Delta variant is very, very contagious. And so it's, I mean, I've said this previously, but previously, if it took you a half an hour, 15 minutes to half an hour of exposure to get infected, now it might only take 15 to 30 seconds to get infected. It's very contagious. The reason that it's so contagious is that the viral load, or there might be multiple reasons, multiple things going on, but typically the viral load among people who are infected is 1,000 times or more as high as the previous variants that we had last December. And so as a result, there's just so much more virus that's put out in the air that this has a lot of consequences. One consequence that it has that it was a hypothesis before, was that we knew that the infectious dose, so when someone was first infected, the size of the dose had an impact on how severe the disease was. And so because the viral load was so much higher, then a lot of us were worried that Delta variant causes more severe disease in addition to causing more infection, more contagious. It's because it's more contagious. And in fact, I'll show you some stuff today that yes, it is more severe. In fact, it's a lot more severe than the Alpha variant, and the Alpha variant itself was a lot more severe than what we had back in December. So the Delta variant, in addition to being much more contagious, is also much more deadly and putting people in the hospital for rates. The other thing that we'll talk about that's a lot of people need to be paying attention to is that previously kids who were prepubescent in particular, were not very good at spreading the disease to other people. They were not very contagious. In fact, we've talked previously about this concept of R0. That's the reproductive value among people who are infected. How many people on average are then infected from them? And when we first started with the Wuhan variant, it was around 2 to 3 on average. Obviously, there were some super spreader events, so sometimes a lot more people got infected. A lot of times people might get infected and infect nobody else. But on average, it was around 2 to 3. With the Delta variant, now it's upwards closer to the ballpark of 10 or so per person. And that's the R0 value that we estimate. And the issue is now, because it's so much more contagious, previously kids had an R0 of less than 1. And for many of them, it was maybe half, 0.5. And that was one of the main reasons that it was okay for kids to go back to school, was because it just simply wasn't very contagious for the kids in school. Now we know that kids are very contagious with the Delta variant. There's so much more when you start talking about a viral load 1,000 times as high. If kids previously weren't very contagious and weren't producing very much virus, now it's pushed them up above R equals 1. So now they are contagious, which means that kids in school, because remember, a lot of these prepubescent kids under the age of 12 have not been vaccinated. And so that means that they can then go and infect other people in their classrooms, which they're probably going to do with high efficiency, and then go home and infect people at home. And so right now we're at this, we're doing a natural experiment. Kids are all starting to go back to school, and we'll talk about this in a little while with some of the questions. And so the issue is going to be, will we start seeing additional spikes in the schools and then in people's houses and just communities all over the country with the kids going back to school, like a typical cold and flu season, except with a much more severe virus with COVID-19. So we'll talk about that. Right now, we're looking in the South. Okay, so here's where most of the cases are going on right now. Again, the two big issues are the seasonality issue, but then also the vaccination rates, and then the Delta. So the three big issues, the Delta variant. As we approach this regular cold and flu season, we expect that COVID-19, or the virus that causes COVID-19, SARS-CoV-2, will become approximately 30 to 40% more contagious, just due to seasonal variation. Part of this could be driven by the kids being more contagious. Part of it might be due to humidity or temperature, other changes in behavior. We don't know exactly all the reasons that are driving it, but we do expect it'll be at least around 30% more contagious, which means that the country that you now see in light green is very likely to become surges again as a result. Even though people are vaccinated, as it becomes even more contagious than it is now, it's likely to rise even more. All right, here's the transmission. I didn't even bother showing this. The whole country is red. In fact, it's so unuseful to have a map like this for the CDC when it's all one color. They really should have another level up so that you can at least differentiate across the country. But right now, the level of transmission is the highest level that the CDC has on their maps. And what this means is that there is no safe activity right now interacting with other people in real life. There's different degrees of safety and versus likelihood of getting infected. So for instance, going to a crowded bar is still going to be more risky than having people over to your house and eating. The problem is when it's this contagious and this much spread everywhere around the country, the risk is going to be quite high. Now, like I said before, the vaccines have continued to prove themselves to be extremely effective at keeping people out of the hospital. And so ultimately, that's the big issue. And so, so we'll talk about the booster. We'll talk about these things for the populations that need it. But the big issue is people who are vaccinated are going to continue to get infected, not to the same degree, but to a still meaningfully large degree. But for the most part, it will be cold-like symptoms. Some will have some more severe symptoms, but in terms of the really, really critical stuff that we were all scared about in terms of being hospitalized and having an early death, the vaccines are really, really effective against those two endpoints. All right, let's go on. There's so many good questions here, so I don't want to spend too much more time. There were just a few things I wanted to talk about. Here's one. So we're already seeing some of the states that were early in terms of their this wave, this new surge. We're already starting to see them peak. And so this is good news. It's influencing some of the models that we'll be talking about. But again, this was largely before the students went back to school. And so the next 2 to 3 weeks are going to be critical in terms of seeing what these curves look like in terms of the evolution of these curves. But this is driving some of the forecasts that we'll talk about. I talked about this one. In terms of age, we can come back to this later if there are questions. So right now we're looking at the hospitalization rate, so that rather not total hospitalization, this is new admissions per day of patients with the confirmed COVID-19 diagnosis per 100,000 people. So this is kids 0 to 17 years old. And when you look at the total number of people that were hospitalized or newly admitted each day, when you compare where we were back in the winter at the peak, so this was back in early January, we are quite a bit higher and we are still racing up in terms of what that looks like. And with the kids going back to school, this is going to just keep on getting higher. Not to say that kids are at higher risk than people in general. When you see here the different age groups, you can see that the people who are the oldest, the 70 and over, are still at the much higher risk of being hospitalized. Some people have still not gotten vaccinated in that age group, and for some, the vaccines are waning. And so they're going to need to be getting booster shots soon. And we'll talk about that in a little bit. But so there is a serious risk that still continues, that persists for every age group. But when we talk about kids with schools now starting, this is something we need to be talking about. Previously, with the variant that hit back in December or so, the common variants, there were a bunch of different variants at that point. Typically, we were talking about the risk of hospitalization being around twice that as the risk of hospitalization for kids for the flu in a bad flu season. And so this was for kids. We knew that the kids were at much, much, much lower risk for this COVID-19 than older groups are. And that's still the case. So when you compare the golds down here, which are the 0 to 17-year-olds, to other age groups, the kids are still at the least risk. However, we now know that this is getting much more severe for kids than an average flu season. And so the fact that kids are not vaccinated is a concern that I have, and this is something as the kids go back to school. We'll talk about the current sum of evidence of what remediation efforts can take place in the schools for going forward. But it's going to be a tough school year, and I suspect there will be some school districts that don't make it through the whole semester, that they might start working from home at some point. All right, that was that. Let me talk about this. Currently, the number of, so let me talk about hospitalizations and that kind of stuff. So let me just come here. So there is, we just talked about seasonal variation. There is a lot of seasonal variation. This is the daily cases. You see that there's the surge, that there's a slight peak there now. And then the open question is what happens as we enter the fall with the increased contagiousness of the seasonality and the kids going back to school. But then let's also talk about hospitalizations. So here's the percent of emergency department visits. You see that the percentage of emergency department visits that were COVID-19 related was almost where we were at the peak in the winter of January, so early January. It's going down now, in particular for a few states that are driving it. But like I said, we'll be talking about this in terms of what that looks like with the kids going back to school. So this right now is the hospitalizations in terms of deaths. So the daily deaths you see is still quite a bit less than where we were with the at the peak, but it's still continuing to rise. And some of the forecasts I've seen are estimating that by September, October, we can easily reach 1.5K deaths per day, and possibly higher, depending on when we reach the peak, whether we reach the peak in September or October. I'm betting it's going to be early October, depending on how things look with the schools. If the current early indicators that we're currently seeing with the peaks play out, then that means this is probably going to end the surge by like early to mid-September, but the schools could drive the big surge is what I'm predicting. All right, so what this means, bringing this all together, currently COVID-19 has now come back as the leading cause of death in the United States this week of all causes. So COVID-19 is back at the high levels we were talking about previously. I mean, not you saw relative, the total deaths are not as high as we saw previously, but relative here in terms of the first leading cause of death, it's still it's hit that ranking again. We still have not all the deaths are reported. So for instance, some people are dying of heart attacks or strokes and have COVID-19, but on their death certificates, it's just listed as heart attack or stroke rather than COVID-19. But we know this is the case because some of the studies that we've discussed previously are demonstrating this. There were a couple more things I wanted to point out here. And so let me just run through these real quickly. All right, the Delta variant, right now, approximately 99% of the, here, let me come to this. Approximately 99% of the, where did I see variant? Here it is. Of the variants in the United States are Delta. So if anyone you know gets infected at this point, it's almost certainly the Delta variant that they've been infected with. There are some other variants still in circulation, but as we've talked about in previous weeks, they're just slowly being driven out. So you can see how previously how diverse the variants were. The problem, the issue is that the Delta variant is so contagious, it is simply outcompeting. It has a higher fitness, evolutionary fitness, and is outcompeting all the other variants in every single country that we look. And so Delta is wiping everything out. Although with Brazil, I see this is odd. The Gamma variant is up again. So this will be something that I'll be looking at in future weeks. Previously in Brazil, the Gamma variant, which has been driven down by the Delta variant. So it's weird that that's going on right now, and that would be something to look at in later weeks. But for now, the story that I'm sticking to is Delta everywhere. When it's in head-to-head races with every other variant, the Delta variant is overwhelming, and the other variants are becoming extinct. So the original Wuhan variant ran out of bodies because the other variants that descended from it were more contagious And so eventually the Wuhan variant became extinct. It no longer exists in the world. And so other variants are going to meet the same demise because Delta is going to continue to drive everything out, or a descendant of Delta that's even more contagious. All right, so I've talked about that. Let me just come back. So Delta is everywhere. There are a few more interesting nuggets here that I wanted to get to. Most of this is not what I wanted to talk about though. I'll keep on scrolling because it was not. All right, you see the vaccinations vary by state, but we've talked about that before. Let me keep on going. Sorry for just scrolling so much. I know it's a little disorienting. We're getting close to some of the meat. Okay, so here's some of the projections that I wanted to show you. So this could go in two different ways. Right now they're saying 3, but it never goes down because we're not going to have lockdowns immediately or mask mandates in 100% of the places. So ignore the purple. The green is the referent. That's what the IHME, the Institute of Health Measures and Evaluation, are saying is what they believe is the most common. And this is the green, where we've already met the peak. And the peak again was driven primarily in the southern states where the vaccination levels were low and that kind of stuff. If that story holds, then green is what you get. If the schools become a meaningful place for people to exchange the virus and transmit the virus and bring and then bring it back into families and then get families reinfected, then what we're looking at is orange. And so the orange, and this is deaths per day, not infections per day. We'll look at that in a second. And so what we're looking at is that sometime in the middle to end of October is when we reach the peak. And the peak will be quite a bit higher. Instead of the 1.4 or so that we've been talking about. This is September that we're looking at right now. So instead of the September 1.4, 1.5 that we're talking about, it could easily hit to 2.5. And in this graph, we're looking at 2.5K, 2,500 deaths per day. So I think that it's personally betting. I would bet more for the orange line, this peach line, than the green line, because we know that kids have an R naught above 1 now, that the kids are contagious. And so that's something. This is, here's infections. So the infections are going to rise. Infections don't bother me quite as much as hospitalizations and deaths. And so we really need to get people vaccinated. There's no excuse for people not to get vaccinated anymore. Kids 12 and older need to get vaccinated as soon as they possibly can. I almost think it's child abuse for parents not to be vaccinated their kids 12 to 15 at this point. We know that the virus is going to be spreading in the schools. There's no way to avoid it at this point. There's going to be masks, there's going to be other things, but they're not going to be as effective as we would like. The vaccines are really, really important. And for kids under the age of 12, we'll talk about that. It's not yet approved for emergency use authorization, and all physicians, everyone's going to be recommending that kids under 12 wait until we get more evidence from the clinical trials. The clinical trials have been evaluating a lower dose because you know that every vaccine has both a risk and a benefit. And so for people over the age of 12, the risk benefit calculation has been really good, that the benefit far, far outweighs the risk. But as you get under the age of 12, because the risk of COVID-19 is so much lower for that age group, it still exists. It's still a major issue. It makes it one of the top 10 causes of death for kids under the age of 12. But because the risk for each individual child is so low, it's not something that it makes it harder to demonstrate the value of the vaccine. So right now, the vaccines in kids under the age of 12 are being evaluated at a much, much lower dose. I think the dose they're looking at is maybe only like 1/10 the size or something. So if a parent was motivated to get their kid vaccinated under the age of 12 with the adult vaccines, which are the only ones currently available, it's the same vaccines for the kids over age 12, it really might not be so safe for kids under the age of 12 when all the clinical trials are looking at the 1/10 the dose for them. So it's probably better to wait. We'll talk about this in a little while. I'll say it now. Now that the Pfizer vaccine has been fully approved, that changes the rules. It changes the law on what physicians can do. Before, physicians were not allowed to prescribe the vaccine other than for what the vaccine was intended. But now there's something called off-label use. And so for any fully approved product, a physician can take it and use it however they want if they think that it's medically beneficial, that if it's medically important that they use it. And so technically, physicians out there can take the vaccine and vaccinate kids under the age of 12. It's not recommended, but they can do it, and we might start to be seeing some of that. Booster shot, it's not currently approved for people who are not immunocompromised. We're expecting that that will come for virtually everyone to be able to do it, particularly for those at higher risk and people who are older. But again, it's fully approved now. Physicians can, as a matter of just legal rights, prescribe the booster shot for any patient that they deem is medically necessary. I don't know what that means for insurers in terms of insurers' requirements to pay for it. The vaccines have been free for us, and I don't know if that would continue to be the case under off-label use. But I don't know. These are things that we'll be watching. All right, a couple more things I wanted to look at here. So we've talked about what this can look like here. Based on these scenarios, we're looking at the surges, like I said, either hitting and peaking in early to mid-September, which I think is a very unrealistic case, or peaking somewhere in October, early to mid-October in terms of infections. I suspect it's somewhere in between. I think that what's going to happen personally is that infections are going to happen more in schools than we were anticipating because of Delta, which we haven't had any Delta before while kids were in school. It only started hitting us over the early beginning of the summer. And so I suspect and so if kids start working from home again, then I don't think we'll reach this peak. But I don't know what this peak is certainly plausible if the schools stay open. And so this is a high peak. And you see it even exceeds where we were back in December or February of this past year under this worst case scenario, which I think is plausible depending on whether we close schools or whatever. So this is something we're going to be keeping track on. I don't want to be too pessimistic, but there's definitely a pathway that I see for this to happen. All right. So now that we've talked about that, I think that was it. There was one other thing. Oh, this is it. So the other thing that's always been the big concern is hospital beds and what hospital beds are available. We already have hit the limit of hospital beds for some hospitals in the South, where there were just so many infections so fast, so many people needed to be hospitalized that they simply ran out of beds. And so this is very problematic. In fact, some places they haven't run out of oxygen. In India and some other countries, we saw they physically ran out of oxygen, and that brings them back to the flu of 1918 levels of morbidity and mortality. But here we haven't run out of oxygen anywhere yet, but we definitely have seen in a bunch of hospitals that the oxygen reserves are falling very low. And there's this risk here, and this is something I'm going to continue to be paying attention to. We're just consuming resources at a higher level, hospital resources at a much higher level than we have for many of these hospitals so far in the epidemic. And so right now we're looking at the forecast of how many hospital beds are going to be used in September, October, and where they're going to be used. And you can see that some states are still going to be at very high risk. Here's Rhode Island is in the red. So far right now, it's been mostly where are we? So this is January. We haven't really seen many June, July. So they're not really capturing the South very much in terms of, I think it seems to be mostly county by county level in much of the South and also hospital by hospital. So here we're looking at state by state. I live in New Jersey. So when you look here, we're mostly in the clear. And so we don't have much to worry about even in the worst case scenario. New York also, this is largely because of our high vaccination rates. However, there's a bunch of other factors that go into play here in terms of the age of the population, the vaccination rates, percentage of the population previously infected, et cetera. So you see that there are some states that are still at high risk: Delaware, Florida, Georgia, Hawaii, Indiana. So not out of the woods yet. And so this is something we're going to be paying close attention to. This is for all hospital beds, and then in particular for intensive care. Again, this is something that we're going to be paying attention to. And this is where it starts to get worrisome, because once you run out of beds, then if people need hospital beds simply for being in a car accident or having a heart attack that could easily be treated, if you run out of beds, then those people can't get the care that they need, and then are at much, much greater risk for increased morbidity and mortality as a result. All right, now that I've spent so much time talking, I wasn't planning on, let's open it up to questions. There are a lot of questions. We haven't talked for a few weeks now.
Okay, so what will full approval of the Pfizer vaccine do?
All right, give me 1 second. All right, so there's 3 things. The first thing is that we're all hoping is that there'll be an uptick in vaccinations. So around a third of people who were not vaccinated said that the reason they were unvaccinated was because the vaccines did not have full approval, that they were just emergency use authorization. And so if we take them at their word, then we should be expecting a quick uptick in vaccinations. Unfortunately, so it's already been a few days. You can see August 23rd is when the Pfizer vaccine got full approval, and yet the slope of the line of who's getting vaccinated has not spiked in any meaningful way. It hasn't gone up. And so we would have already started to see a big signal, I think, if this really was the trigger that people were waiting for, that they knew the vaccine was important, and the only reason they weren't doing it was because of the approval process. We would have already seen a signal, and we don't. So I'm very skeptical that we're going to see a much bigger signal because of full approval. However, we do see that this trend is continuing to go up. So it's going up slowly, but people are still getting vaccinated. It's still trickling in, but it's better than nothing. Hopefully, as the school season starts, I'm hoping more and more people get vaccinated, but we'll have to see. The second thing is off-label use, which I mentioned. As I said, for kids under the age of 12, I think for many people, it's going to be better to wait to see the results of the clinical trial, primarily again because the dosage is different, and there are some issues that the clinical trials are investigating. However, now physicians can prescribe off-label, and this is a choice that some parents will be making. Third, I think that there's going to be a lot more mandates. And by the way, this came from Caitlin Jedalena. She's a great epidemiologist that has produced some great work. But I definitely agree. The mandates, we're already seeing more mandates now that there's full approval. And I think that's going to continue for many places of business, for many events and whatnot. And I think that's a good thing. And then fourth, which some people are not talking about, is now that Pfizer has full approval, they can market it. And so they've been making a lot of money on the vaccines. And so now they have a marketing budget. And that means presumably they can take out TV campaigns, they can do other advertising, and hopefully that, typically marketing has a big impact on getting drug or vaccine uptake. And so I'm hoping that this can have an impact. We will see if they do effective marketing, and then two, what that impact is on the vaccine uptake. And so this is something I'm looking forward to. But that's all I have so far on that.
Okay, the next question is, should ivermectin be used to treat or prevent COVID-19?
Oh yeah, this is the tricky one. So no, it's not tricky at all. It's a very, very simple answer, but here's the issue. So ivermectin was FDA approved to treat parasitic worms. So it's primarily used to treat parasitic worms in livestock. Early on, in some, I believe it was in petri dishes, it was found that it could be possibly used to treat COVID-19 in terms of the SARS-CoV-2 virus. So it was seen as a possible candidate for treatment. But like hydroxychloroquine, ivermectin was one of these drugs that has been evaluated and failed. The problem is that a lot of people now who are vaccine hesitant, for some reason, even though ivermectin is not approved for COVID-19, they assume that because it's approved for something, that it must be safe and effective. And it is safe and effective for treating parasitic worms in horses. There are some uses in people that is also proven safe and effective for if people have parasitic worms, but it's not approved for long-term use. It's not approved for high doses, and people are using this off-label and without a doctor's prescription, although some doctors even are prescribing it because they're crazy, silly people. And now people are getting poisoned with ivermectin, and the poison hotlines are being filled, and people are going to the hospital, and some people are dying because they're taking ivermectin. So this is a very serious thing, to the point that the FDA put out an advertisement: you are not a horse, you are not a cow, seriously stop taking the ivermectin. And so it's a real big issue that the FDA would even have to look at this. Let's jump in just for a couple minutes looking at the evidence. So this was a recent systematic review and meta-analysis. So looking at all of the trials that were published on ivermectin, the level of evidence hasn't been very low. Typically, the early trials were the ones that suggested there might be some benefit at all. But on reflection, when you look at all of the trials, let me make this a little bit bigger. You can see, so whenever we look at trials, relative risk or risk ratio of 1 means there's no effect. And if it's higher than 1, then it means it makes it worse. And if it's lower than 1, it means it prevents it and it makes it better. And so you see, now that we've had a lot of different clinical trials, they've all hovered right around 1. And when you add them all up together, you get this blue dot right in the center. Let me make it really big. And the blue dot is right at 1. So there's no effect, no benefit of taking ivermectin. It is not something that anyone should be prescribing. And the primary reason is this. So the early trials, I mean, even though in addition to it being ineffective, if some people say, well, even if there's a possibility that it's effective, if it's safe, what's the harm in taking it? The problem with the harm is this. So even though we know now that it's not effective, there is an additional harm, and that's the poisoning. Originally, it required 5 micrometers of concentration to, or micromoles, or whatever this unit of volume is, concentration to reach the level of observed in the petri dish. And in reality, in people, you can't get it really much higher than around half of that in the blood, which means that if something works in the petri dish at a certain concentration, but you can't physically give a patient enough of the dose to get it that high in the bloodstream, then that's another reason that it's going to cause problems, both safety problems because you're giving the maximum possible dose that was possibly reported, and also it can't reasonably reach this level of effectiveness. And so this is what's leading people who are taking this drug, because previously, again, this drug was for parasitic worms. It poisons. It's a poison that people are taking for themselves and causing problems. But the major conclusion here is this, is right here. Ivermectin does not reduce mortality. It does not reduce hospitalization or length of stay or viral clearance or anything else. Do not take ivermectin. So that's the story. The evidence is here. Overwhelming evidence. Don't do it.
Okay, Glenn, I know we've talked about the children going back to school. Should we worry about them going back to school, and what interventions work best for reducing the risk of COVID infection in schools? And the face masks that they wear, which ones should they wear are the most effective?
All right, let me jump into this. There's a lot that we can talk about here. I think so the biggest takeaway before, I didn't want to be too pessimistic before. The biggest issue right now is that kids really are much safer. The risk in kids, especially kids who are prepubescent, who have not been vaccinated, is orders of magnitude lower than people who are older, and many orders of magnitude lower than, say, people over the age of 70. So we just have to always, and whenever we talk about this, we have to keep this in mind. Having said that, this is still a serious illness in kids. It's still multiple times more severe than a typical flu season, and it is something we need to be paying attention to. So for instance, here are some stats. Already there is a hospital, so this is just so far, and so I don't want to say it's like all the hospitals are like this, but right now, end of August, this is from this woman who just tweeted out, that there are currently now no staffed pediatrics ICU beds available in this area that she was working. And so this is problematic, and we might see more of this. The problem is pediatric intensive care unit capacity. Kids are not adults. Kids require different masks. Kids require different blood pressure cuffs. Everything that we use for adults, it just doesn't fit on kids. So kids who need intensive care need to go to special pediatric intensive care units. And there's only a limited number of them in the United States. In the United States, we have in total 4,500 pediatric intensive care unit beds spread around the United States. And so the question is, based on what we know about COVID-19, the risk and how contagious it is, what does this look like in terms of not necessarily a forecast of what will happen, but what's the maximum? Are we at risk of even reaching anywhere near that? So far, we know roughly 38% of kids have natural immunity, which means that we have an estimated 34 million susceptible children in the United States. Right now, our best estimate is that around 1 to 2% of infected children are hospitalized, and that 33% of the hospitalized need to go to the pediatric intensive care unit. And the average stay is 4 days. If you put all these numbers together, then that means that as the kids go back to school around the country over the next, so if we're now looking September, October, over the next 2 to 3 months, we may need maximum, this is if they all, every single one, 100% were to be infected, which is unlikely to be the case. But if 100% were infected, we would need 6,800 of these intensive care unit beds. We only have 4,500, and the 4,500 is for everything. If a kid gets into a car accident, if a kid has cancer, if a kid has this other serious diseases and requires to be in the intensive care unit, all of those things fill up these beds in the 4,500. So the fact that our upper limit could be above that, remember, Delta is so contagious that very likely every single person in the United States is going to get infected within the next 3 to 12 months. It's just so contagious. It's going to be very, very hard to avoid. And as kids go back to school, we're almost certainly not going to reach 100% in the next 2 to 3 months, but we're going to reach quite a lot of people. And so this has the potential to get bad. If we looked at the graphs that I just showed you, looking at September, but particularly if we continue going into October and peaking in October, then this is what these numbers are really going to be worrisome. In terms of transmission, like I said, we know that the kids R0 is above 1, which makes kids contagious now. They're sources of contagion. Before, all the sum of evidence we had before Delta suggested that kids just weren't very contagious. It was one of the reasons, one of the points of evidence of why we were saying kids should go back to school was because just kids weren't very contagious. And if you had kids infected, they were very unlikely to infect everyone around them. That has changed now. And so it's unfortunate. Kids need to be back for many reasons. In-person learning, they learn better. They have social development. There's all sorts of reasons, but Delta is really problematic for us now. Let me go on to some other things. One of the things I was looking at was school openings. So school openings vary by region. So you can see that there's a lot of different regions in the country. The earliest ones to open seem to be East, South, Central. This is from 2019. I'm assuming that the opening dates are consistent now, that they would be pretty consistent year over year, that they might not have changed very much because of COVID. So I don't know if that's actually true, but if the opening dates are roughly the same, then that means we can look to East, South, Central, which opened at the beginning of August, and we might already be able to see what's going on there. So I looked at that. Currently in East, South, Central, there are 4 states: Tennessee, Kentucky, Mississippi, and Alabama. You can see that a couple of them started to peak. So for instance, Mississippi started to peak and is coming down. The Tennessee started to peak, started to go down, and then there's a little slight signal that this is starting to go up again. I don't know what that means. The school now is when you would start to expect to start seeing some of a signal. So it could go either way. It could go up or down. The next time we meet, we'll have more information about this. But you see the other 2 states, Kentucky is just continuing to go up. And Alabama, which went down a little bit, is continuing to go up. Let me dig into this a little bit more here. So if we look in early August is when most of these started. Early August is around here. And so by the time we have the end of the month, then that puts us, you can see that there is just, it was continuing the trend that it was on before. But you can see that, so this is Tennessee that we're looking at. Tennessee, this is percent positive. So the percent positive has not peaked and started coming down. In Tennessee, the percent positive has stayed roughly the same and started to increase some. In Mississippi that we're looking at, we see a slight decrease in cases here, which could continue. The case, so if they started back in early August, so around here, then that means that the kids could have started to get infected, start to pass it around, and then we could start to see in the next week or two the numbers to go up, or the trend could continue down. And so this is really just an experiment that we're doing with the kids, and we will see. And it could go either way, but I think that this region is what we'll see first. So in the next week or two, I think we'll have pretty strong evidence the next time we meet to see what's happened. We did see beginning of August again is here. This is Alabama. Alabama reached its peak and was starting to go down, and then it started to go back up again as the school, now that the school kids were back in the schools. Here we have Kentucky. It just never went down. It just continued. I mean, maybe a little bit down, but it just continued going up. So it's still an open question. I would say it's that their evidence is not 100% certain that the kids go back to school and suddenly you have this new spike. But based on what we're seeing here from these 4 states in the early states, it's a very reasonable assumption that the kids going back to school could lead to an increase in the surges. So this is something we're going to be looking at for sure. Right now we're looking, this is hospitalizations and deaths, the same data, but it's telling the same story essentially. The surges are continuing to rise. Mississippi is the exception here, but the schools are back in session, so let's see what happens. All right, having said that, I'm spending too much time on this, so I'll go through a little bit quicker. Here, we're looking at other viruses, other respiratory viruses other than COVID-19. We know that they dropped dramatically, so the kids just didn't have the sniffles in general. We got much lower levels of RSV, which is the, respiratory syncytial virus. The flu is almost non-existent now. You see where the flu was in 2020 before the COVID-19 lockdowns. That was the dark green and the light green were the flu. The flu virtually eliminated. There's a little bit here, a little bit here. You see a little bit, and there's still a little bit here. But you see right now we're in end of August, and there's virtually no flu. And it's still a little bit early in the season. I mean, you'd expect it to start September, October, that you'd start seeing it, but there's virtually none right now. And so that means that if we continue mask wearing and whatnot, and having these other mediation effects or mediation interventions for the schools, then we might not have the flu, which would be good. Because some of these other things, the worry is that with RSV, and if we do start getting flu, that could be more serious this year than in previous years because the kids have lost their immune memory because they haven't been exposed now for a while. And so that's something that, but luckily the flu seems low so far, but I'm going to continue to track that. So here, so this is the main thing I wanted to get to here for talking about kids in schools. So here, this was a study looking at SARS-CoV-2 aerosol transmission and the effect of different interventions. During the summer, opening all the windows all the way, all day long, had a 7-fold impact on reducing the risk of SARS-CoV-2 infection in the rooms. Whether it was a camp room, a classroom, anything like that, had a 7-fold reduction. If you kept the windows mostly closed, but hourly, you open them for a while to air out the room and then close them again, you see it had a limited impact, roughly 1.5 to 1.8, depending on how many windows you open. So that the more windows you open, the bigger the impact. If you only open 2 windows, then it was 3-fold impact. If you open 6 windows or all the windows and doors, then it was 7-fold impact. If you just opened it a couple times a day, say during the lunch break or recess or whatever, then it had, again, very minimal impact. In the winter, the impact is much, much larger. You see a 14-fold impact if you keep all the windows open all the time. That's hard to do in the winter, but the impact is so large, it might be worth it for these students. So the students, in addition to the masks, might need to be wearing the winter coats in the classroom. And guess what? For a severe disease like Delta, just for this semester, like I said, I've been talking for a while, I think by March, Delta is so severe and people are getting vaccinated at a rate that I think by March, most of this will be done. I'll probably have to eat my words depending on what it looks like. But the big issue here again is the hospitalization rate and the mortality rate. Once the hospitalization rate goes way down because everyone has immune memory, then it's not going to be the same kind of issue with this virus. It's really going to be more like a cold virus at some point. And so then we're really not going to be as worried, and people can get infected and you just won't care because it's going to be mostly like a cold virus. We're not there yet, but I do think the end is in sight at least. I believe it's going to be by early March that we'll have hit it. It might be sometime after that. And we are also looking at the variants globally that might disrupt that. But as I've said before, I think the Delta variant is just the fitness level is so high. I think it's going to just continue to outcompete any other variants that have been identified so far. So this is opening all the windows. Again, if you only open some of the windows, it doesn't have nearly the impact. If you only open them for part of the day, it doesn't have nearly the impact. This is all day, the 20 centimeters versus 60 centimeters. This is if you open it part of the way versus all the way. You can see that opening the windows all the way has a meaningfully different impact. It's much, much larger opening the windows all the day, 14-fold, versus if you open the windows part of the way. Even if it's all the windows open part of the way is 5-fold impact. So it's much better to open the windows all the way. When you compare these HEPA filters, if you have a really, really extensive, the best in line or best in class HEPA filters, then you have a 41-fold impact in terms of the impact that you're having on this part. When you also have natural ventilation, if you don't have the ventilation as part of it, but you have the HEPA filtration without the outdoor ventilation, then you still have a major impact, but it's not nearly as high. If you have a moderate HEPA filtration, but not the best one, you still have a meaningful impact. And so let me go on from there. This on the right is what happens if you keep the windows closed and just look at the HEPA filter. So this is the windows closed, but no HEPA filter is the orange. The dotted line is the cumulative. That should be the main one we're looking at per 8-hour day. Time is the issue here. So every day it's a cumulative exposure. And that's really what makes all this stuff, the risk just accumulates so fast, is that for contagion, where just 15 to 30 seconds of exposure could cause someone to get infected. 8 hours of, even with the masks, even with all this other stuff, makes the risk high. So what we're looking at here is not comparing one HEPA filter, which is blue, has a significant impact, still a meaningful impact, but a significant reduction. The green has an even bigger reduction. Now, if you look at those same curves, so now it gets a little bit more complicated. Now we're looking at windows fully. So this is windows closed is orange. If you have windows that you only open during the breaks, but then close them again when the class is in session, the blue line looks very similar to the orange line. You see the cumulative, the dotted line is still, it's a little bit lower, but not hugely lower. The dark blue is windows slightly open all the time, not fully open, but slightly. You see that reduces it a lot more, but not all the way. Green reduces it much more. What if you keep the windows closed but have surgical masks? You see that it drops the blue dotted line here, drops it dramatically, but it's still a meaningful exposure. It's still a meaningful risk that the kids have. Now, if you, yep, I see just a little bit more and then I'll move on. Next, if you compare windows closed and surgical masks, we've looked at that. If you compare the surgical masks and the HEPA filter and the window, you get this green line, which is the best of all cases. You see, if you compare this green here to the previous one that we were looking at, you see that these are much, much higher. The green, the only way to get to green is to wear the surgical mask, not just any mask, surgical masks and HEPA filters and windows open. Let's talk about masks real quickly. Let me come back over here. There's a couple really good guides that I've seen online. Good is wearing masks that are any mask is better than no mask. Better is to double mask. So all kids should be doubling mask at this point with the Delta variant. What that means is that they should use a surgical mask or a KN95 or KF94, one of these big masks. Ideally, what they should do if they don't have the KN95 is to wear a surgical mask and then wear another mask over it. So because the surgical masks are very hard to fit. And so that works better as a filter. If you put another mask on top of it that is much better fit, then that works best. And so that's what we should be doing is good. The best, but even better than that is a genuine KN95 or KFN94 made specifically for kids. These masks are not one size fit all. If the masks don't fit the kid's face, then the masks are not going to work. So for instance, if a person wears a mask and it fogs up their glasses, the mask isn't fitting well because it means that the air is coming out. And you can see that because it's fogging up their glasses, which means that any aerosol, any SARS-CoV-2 in the air can be breathed in just through that gap in the mask. And the mask at that point has very limited efficacy. There's still some efficacy, but it dramatically reduces the benefit of the mask. That's why we really need to get these kids masks. And so we should be looking for KN95, KF94s specifically for kids. This is a website that I found that was useful. If you Google these people's names, Aaron Prusson, Lindsay Marr at the Virginia Tech, they have a good guide. This other guide that I saw that was good is by this woman, Eva Enns, who's at the Division of Health Policy and Management, University of Minnesota School of Public Health, Masks for Kids. She's saying essentially the same thing. We need to get kids the N95, K95, or KF94 masks that fit them. It's critical to make sure if it makes them more comfortable. So these kids the masks have to be very comfortable in order for the kids to wear them. And so you might consider getting the nose, the things that are made specifically for the nose to make the fit a little bit tighter and more comfortable. Then they also have these mask brackets you can put under the mask. But these are some of the recommendations that this person is recommending. And you can see double masking, I think, is the way to go if all you have are a surgical mask and then some other mask on top to hold it on tight. Again, Google this one if you're interested. This one is Eva Enns, EVAENNS at the University of Minnesota School of Public Health. All right, I know we're almost at the time. There's a bunch more questions that I can go to. I think that what we've talked, spending the time, I think, on what we did, I think was important. But Arlene, how about 3 more questions? I'll go somewhat quick.
Okay. I heard there's a new variant called the C.1.2 that is spreading rapidly. Will this never end? Do we need to be worried?
All right, let me see if I can find this real quickly. Where was this? Here it is, C1. Okay, so C1.2, we keep on hearing of new variants, and we're going to continue to hear about new variants that physicians and researchers are worried about. And the reason they're worried about it is because they've done studies in the lab and they might see it looks crazy in the lab when they study it under laboratory conditions. This one is C.1.2. It fits that criteria. We saw it was starting to spread. It was very contagious. We first found it in South Africa back in May, and it started rising rapidly. We also started to see it in UK, where it rose to much more commonly. New Zealand, Switzerland, China a little bit. The issue is the same as the other ones, is that, right, so this was considered it wasn't named by the World Health Organization, so it doesn't have a Greek letter yet, but it would have fallen under the gray, under the others. And so when you look at South Africa, this was July, the middle of July, 6% of South Africa were these other variants, and 89% were the Delta variant. But now when you look at South Africa, 100% of the variants circulating are the Delta variant. Delta is so contagious, the fitness level is so high, it's wiping out all the other variants. So this is sort of this is the good thing though, is that we don't have to be as concerned for almost any other variant that you might read about in the news. We don't have to be that concerned because Delta is making those other ones go extinct. So that story might change in another year or two as everyone starts to get immune memory And then there might be some breakthroughs that we need to, or breakout variants that we need to worry about, and we'll get new vaccines at that point. But for now, this is nothing we need to be concerned about. The surges are mostly going to end now. The hospitalizations are going to go way down because between Delta and the vaccines, everyone's going to have some immune memory within the next 12 months or so. It's just happening too fast. All right, next question.
All right, we have to close this very soon because we're now a little bit past the time. Do vaccines reduce transmission of the Delta variant?
Vaccines reducing transmission. So yes, the short answer is yes. Vaccines do reduce transmission of the Delta variant. One thing that we've talked about before was that we did find the whole reason we started wearing masks again among people who are vaccinated was because we found among people who were infected and vaccinated, the viral loads were as high as people who were infected and unvaccinated. However, now we have good research that's come out since then, and we found that among people who are vaccinated and infected, even though they might have a high viral load, it turns out because they have antibodies, the antibodies are making it so the virus is not viable. So even though there's a lot of viral load, they don't infect other people at the same level. To the degree, I don't know that I put it here, but so they are still contagious. They're not as contagious as people who are unvaccinated. So vaccinated people, here's the key graph here. So this is comparing viral load here, it's on the x-axis, to probability of being contagious.
Thank you.
And you can see that the people who are unvaccinated at a much lower viral load are much more contagious. People who are vaccinated require a much higher viral load in order to become contagious. You don't know someone's viral load just by looking at them. So if you know someone's been infected, they could be contagious. But vaccines definitely do reduce transmission at the end of the day. That's the big question here. It does not eliminate transmission, but it does reduce it some, so that's still good. But again, remember, the whole point of the vaccines was to keep people out of the hospital. So it's just an added bonus that it also reduces transmission some. But they're not extremely effective at reducing transmission of the Delta variant. They were better for other variants. The Delta variant, like I say, it's just so overwhelming, so contagious. It's just hard to prevent the transmission. But even against Delta, they do seem to have some effectiveness. One more question, but before we go on to your last question, I just wanted to mention this. There was this question about severity. Is the Delta variant more severe, more dangerous? And so we had this hypothesis that because we knew that the infectious dose increases, that the higher the dose, the more likely you are to have severe disease. There was this hypothesis that because the Delta variant viral load is so high, that the infectious dose could be higher and cause more severe disease. We found in the United Kingdom that the Alpha variant caused people to become around 50%, it caused 50% more severe disease, order of magnitude, than the previous variants that we had last winter. Now what we're finding is that the Delta variant is 2 to 3 times more dangerous than the Alpha variant was. So in addition to the Delta variant being more contagious, if someone's unfortunate enough to get infected, it's a lot more severe than previous. And so this is another issue. Now, with that, so this is the major study that just came out in the Lancet with that. It's pretty, you can see it's pretty consistent. It's not quite as high, it's still pretty high for whether you're vaccinated or unvaccinated, but this is the story. Delta is more severe. All right, Arlene, either 1 or 2 more questions. I can knock them up.
We should make it probably one more question. Do we know anything more about the long-term consequences of being hospitalized with the COVID-19 virus?
Yeah, unfortunately, that's not that. Let me see. Yeah, so there's a new study that came out looking at hospital survivors after a year. And at the longest study before that looked at them at approximately 6 months. There had been some that looked at 7, 8, 9 months in terms of infection. But in terms of looking at long-term sequelae for this population at 6 months, this is coming out of China. So looking at this longitudinal study, they found that there was a small increase in trouble breathing, dyspnea, and in anxiety and depression after a year. So there might, in addition, there were lingering sequelae, so lingering symptoms of other sorts as well. Other symptoms went down, but for some strange reason, some of these went up. But so, for instance, fatigue and muscle weakness, it didn't go up at the end of the year. It stayed pretty strong. And so, as a result, they're trying to figure out what things could help to determine why someone would be more likely to have fatigue or muscle weakness. It's not exactly clear. Some of these are showing, okay, maybe it could be that people who got corticosteroids had a little bit more fatigue or muscle weakness a year later. However, I don't know how to interpret this, because it could simply be that the ones who got corticosteroids had more severe illness or some different comorbidity or something else going on. And it wasn't the administration of the drug that caused the fatigue. It was just a biomarker of or a marker of the disease, a confounder. Similarly, they found that women were slightly more likely than men to have fatigue or muscle weakness a year later. When you look at some other things, in terms of anxiety or depression, again, women were almost twice as much or twice as likely as men to have this, to report this 1 year after being hospitalized with COVID. And then that was the major thing there. And then diffusion impairment. Again, this is trouble breathing. That the more severe the illness, the more trouble breathing they had later on. It didn't get better for many people, it got worse. This might have been for, there might have been scarring of the lungs or other problems with the lungs that are causing these longer term issues that we need to follow. And so that's the thing. I've reported previously a study that came out that demonstrated, this was in the Veterans Health Administration in the United States, that among people who were hospitalized with COVID-19 and recovered 6 months later, they were 50% more likely to have heart attack, stroke, or other severe illness than people who had the flu and were hospitalized and recovered 6 months later. And so there are lingering issues that we don't fully understand, just persistent inflammation or other things, other cascades of things going on in the body that we don't fully understand yet. And there are long-term consequences for the illness. This is another important reason for people to get vaccinated. We're still looking at this among the vaccinated, but among people who are vaccinated and infected, we don't expect to have these severe illnesses. The people who are vaccinated are not going to the hospital in the same numbers. It's a tiny fraction of the numbers. So that we know that that the virus, if there's any worry at all about long-term consequences, people should be afraid of this virus that infects their heart and infects their testicles and infects their liver and infects their kidneys and infects organs all around the body. So it's a very severe disease. And one as a parting note, if we don't want to talk about any more questions, well, keep the rest until the next time we meet in 2 weeks. As a parting note, people are continuing, some people who are against the vaccine are continuing to say that COVID-19 has a 99% survival rate. And technically that's true, but AIDS has a 99% survival rate essentially for most people in the first few months that they're diagnosed, if they haven't been previously treated. Once it's found, we have very effective treatments, and we can bring people under control very quickly. For the most part, AIDS is a very serious disease, but most people don't realize it's a very treatable disease. And so when you're talking about 99% survival, that does not mean 99% recovered. And so other diseases that are quite serious are prostate cancer. If someone's diagnosed with prostate cancer, the vast majority of people are going to have it for years and not die in the first month or two after that diagnosis. The vast majority will have many more years of life after that first diagnosis. And so it's the same thing. Just because something is not immediately killing you that day or that month or so within the next 3 months, it doesn't mean it won't eventually kill you. And so prostate cancer is a very serious illness for a lot of people. And so just because something is 99% survivable does not mean it is some innocent disease that is harmless. A lot of people have long COVID, have these really serious illnesses. What we're just discussing here with the long-term consequences, some people don't even get some of these long-term symptoms until a year after they've had it. Now, with this study in China, it's just the first. We're going to be looking at this more closely. No one study is the end end of the discussion here, but the fact that we're finding some of these early signals a year later is something that's meaningful and something that we need to keep an eye on. And so this is something we will keep an eye on.
All right, thank you so very much, Glenn. You once again have been extremely helpful. Can you tell us, are you going to be meeting with us again in 2 weeks?
Yeah, that's right. So now we're back to the normal timeline. So in another 2 weeks. So what are we looking at now? So right now it's August 29th. So September 12th, same time, 7 p.m. We'll have the live Zoom meeting.
Same time, same place. Well, thank you everybody for coming. Rebecca will be back next time and she's on vacation now, but thank you very much and everybody be well.
Thank you. Have a great week, everyone. Bye-bye.
Bye-bye.